please.
All right. My name is Mary Beth Callahan. I'm a social worker and the supportive care team manager at Dallas Nephrology Associates.
So could you talk a little bit about what you do in terms of sort of helping people with advanced chronic kidney disease understand that there is this non-dialytic option, and then how you follow them to make sure that they receive that type of care?
All right. I have found that it's more complex and more time-consuming than I anticipated when we really try to follow the patient and help everyone understand that maybe they don't want to go to the hospital. But a patient might be identified and sent as referral to our supportive care team. I will try to talk with the patient and or family members to identify what their thoughts are, what their values are, what their wishes are. And then I look at what resources might be available to them. We're fortunate right now in the Dallas County area to have be a part of the Medicare Care Choices model, which allows home-based palliative care. So that's been very helpful for many of our patients. What often happens is getting the order from the physician and the right diagnosis to qualify for this, and helping the family and the patient to understand the differences between home health, home-based palliative care, and hospice care, and to try and honor the patient's wishes about where they are in that process and how it can best support them for quality of life. And yet, many people, as you know, are resistant to hospice, whether that be the physicians or the patients or family. And so home-based palliative care has landed more softly with the patients and the family. And I think the earlier in the trajectory of the disease process that we can talk with them and build that relationship, as you know, that's so important, then we can hope to keep them in a comfortable place at home if that's their desire.
It's new for nephrologists. We're not trained during their fellowships, by and large, with active medical management without dialysis. It's a real alternative to dialysis, and I think many are just adjusting to that now, and especially as there's more and more research that certain patients are not really good candidates for long-term dialysis. So do you think there's a certain type of patient that the nephrologists in your practice are starting to more readily identify as not likely to do well on dialysis?
Well, that has been a negotiation, and I think where we are right now is as a pilot project at one of our clinics, the physicians have developed a comfort level that if the patient is over 80 with CKD 4 or 5, then that's kind of a trigger point. And that's pretty deep into the process, but that is where they're comfortable right now.
Okay. And what about cognitive impairment? What if the patient has some dementia or bad heart or lung disease? Does that play into it too?
Well, it could. One of the things that I sometimes do is look through the patients that are coming into clinic that day and see if there's some comorbidities such as those, and maybe just talk with the doctor briefly or lay out something that might be possible, and then they can refer or not refer. So those are important factors, but I don't find that those are necessarily referral triggers.
Okay. Well, give me an idea. How many patients would you say you've interacted with over the last, let's say, 3 years who've chosen a non-dialytic pathway?
I think when we think of the patients that have had a serious illness conversation, bills of care discussion that's documented, we'd probably be about 130 or so. Now, more recently, we are closely following the patients who are still in the group that have been referred to us. I try to be in touch with them on a monthly basis, or their family, to understand what their changing needs are. And that population we're looking at more closely in terms of, can we keep them out of the emergency room if that's their desire? So the other thing I'd like to say is that I find that when we have a patient referred and go through the process with them, and they have a death that is consistent with their values and their wishes, and that's related back to the referring physician, I think that builds confidence in our program as well.
Okay, you're saying a death with a good outcome? Is that what you're saying?
Right,
okay.
right.
And that's what all three programs are trying to do, are trying to keep patients comfortable and out of the hospital, not have them in the emergency department at the end of life. If they really don't want to start dialysis, trying to help make sure that that wish is honored, because sometimes the clinical momentum, if a patient with chronic kidney disease ends up in the emergency department and their potassium is high, sometimes the wheels just get turning and what the patient has consistently said seems to get lost. Something that you said that I just want to follow up on. You said if the nephrologists see that a patient who's pursued, one of their patients who's pursued a medical management without dialysis pathway has a good end-of-life experience, helps to build their confidence in this as a reasonable option. Did I understand?
Correct. Right.
All right. So how many different nephrologists do you think have had that sort of, it's almost like it's an aha moment or the light going on, right?
Right. I would say that it's probably, not counting Dr. Hansen, of course, I would say 5, maybe.
Okay.
Family members, it's that experience of loss that when we first start talking about it, they want to encourage the patient that they'll take care of them through whatever process. And so I really do find that it's multiple series of conversations to help the family perhaps grieve, feel more comfortable with the process, and to get to honoring the patient's wishes. The other experience that we've had is that when there are family members that have different desires for the patient becomes ambiguous about what their choice is going to be with medical management, without dialysis, give it a trial. And so it's really trying to hone in on honoring the patient's wishes, and what are those?
Yeah, so we just can't say enough about the family's involvement. Years ago, I did a study of ANNA nurses, dialysis nurses, the dialysis nurse, and we asked the nurses, what percentage of your older dialysis patients do you really think didn't want to be on dialysis? And they said it was about 15%. And part of the was to ask, well, why was the patient on dialysis? And it was because the family had insisted that the patient, and they really felt like the patient was not doing well on dialysis, had a poor quality, didn't want to be in the dialysis chair. And so I think part of making a medical management without dialysis program work is really dealing with family issues. It would sound, definitely would agree with that.
Absolutely.
And that the nephrologist, although the nephrologist could do that, many would just as soon allow the nurse or the social worker to have those conversations.
Right. And I do think that, as a clinical social worker, our training is in the person-environment fit and systems theory. So I do feel that we can be very helpful. And again, multiple conversations I think are needed to help everyone come to the same page.